Hello, everybody. Welcome to your chest and lung injuries lecture. I hope you all are safe and healthy wherever you are in the world again. If you haven't done the readings for today for this lecture, no worries. Just follow along with me on the slides. All right, let's dive into a little bit of chest and lung anatomy. Our main concern here with any chest injury is going to be the compromisation of that respiratory or cardiovascular systems. The respiratory system is the system that provides oxygen to and removes the carbon dioxide away from the body. Let's focus on the chest cavity here, like we see in the photo on the right. The chest cavity consists of the clavicles, the rib cage, and the diaphragm that form the boundaries of this cavity. There are 12 pairs of ribs in every human being, and they're attached to the spine in the back of our bodies. The upper 7 ribs are attached to the sternum by cartilage. The next 3 below that are attached only by cartilage to the rib cage, and then the lowest 2 ribs are going to be the floating ribs, and they're attached only to the spine. We're going to talk about the different airway passages and how oxygen gets from the environment into our body and how our body uses this oxygen. So in any form of airway passage, it starts at the nose or the mouth. So the air goes into the nose, into the mouth, into the pharynx, which is in the back, down to the larynx, which is our voice box, down through our windpipe called the trachea, and then into our bronchial tubes. So when we take that deep breath through our nose or mouth, that air is warmed and humidified, and then it's moved down through our voice box and down our windpipe. It travels to our bronchial tubes that enter the lungs. There's this thing called the epiglottis. This blocks our windpipe, so when we swallow, no food or anything can get into our lungs. When you breathe out, our air leaves the body through these airways as well. So let's talk about the lungs. So the lungs are located on either side of our breastbone in this chest cavity, and they're divided into 5 main sections or lobes that we won't really get into. The lungs, they're responsible for removing that carbon dioxide from the blood and then adding oxygen to it. The heart and lungs work together really, really well to do this. The lungs contain thousands of tiny little tubes that end in like little tiny bunches of air sacs or our alveoli. Each one of these sacs is covered in blood vessels, and they connect to a system of veins and arteries that move that blood throughout the body. So when you take a breath, the pulmonary lung artery, which is in the right in the middle of our chest, it branches and brings blood containing lots of carbon dioxide and no oxygen into these vessels. The carbon dioxide leaves the blood and enters into the air, and oxygen leaves the air and enters the blood. So once the blood has plenty of oxygen and no carbon dioxide, it is returned to the heart and then pumped to the rest of the body. So the diaphragm is going to be the main muscle responsible for our breathing. It separates the chest and abdominal cavities and contracts to help inflate those lungs. You can hear and we talk about our intercostal muscles, and these are those muscles between those ribs, and these give the lungs room to breathe by expanding and contracting the chest cavity. The abdominal muscles, these muscles give the lungs room to breathe also by compressing the organs in that abdominal cavity. And then those neck and upper chest muscles, these muscles help you breathe when lung disease or any damage to other muscles make breathing difficulty. So everything is connected in the chest and lung area, and any trauma to this is going to be very, very severe and compromising, our respiratory system. And like I've always said, if you don't have an airway, you don't have a patient. There are a few different types of chest and lung injuries that we are going to be talking about in this lecture. The first one is fractured ribs. These or a clavicle. These are not going to be a very severe injury, but we're always going to be for monitoring for signs and symptoms of any respiratory distress or difficulty, because that's what the main implication of any trauma to this region is going to occur. So a fractured rib is basically, as you see in this photo, parts or a couple ribs have just been fractured. They have not completely broken off. They may be completely severed or slightly fractured. This will present with point tenderness pain. So this is going to be a symptom. Any deformity and or discoloration. So bruising, like you see in this top photo, is a clear sign of that. If the patient is having pain on any inspiration, or if their respiratory rate is increasing, they're having really like shallow breaths like that. And this thing called anatomical splinting, which basically means they're protecting that side. They're holding their rib cage, their chest. They're having some sort of difficulty breathing due to the pain that these fractured ribs are causing. So for this injury, there's really not much we can do for it inside the hospital and outside the hospital. So our best form of treatment is monitoring that pain. We can give this patient some different pain medication, paracetamol, something like that. Um, and then we want to make sure that single rib fracture that is not displaced usually does not require any splinting. So you don't have to really wrap this patient hard. If it does, you do want to put this patient in a position of comfort. So that can be a sling and a swath. We'll learn that in our splinting lecture. You can tape that fracture site from the sternum to the spine, anything that's comfortable for this patient. But like I said, there's not really much treatment. If they're presenting with these small, mild symptoms, they're not having any trouble breathing, just a little bit of pain, we're just going to be monitoring this patient. And if it does progress to something more severe, we will take them to advanced care. The next injury we'll be talking about is a flailed chest, and this is a very, very serious chest injury, and this is usually due to some sort of trauma. So a flailed chest is when 3 or more adjacent ribs are broken in 2 or more places. As you can see in this photo, they are completely broken off from the rib cage and then are basically floating within inside this chest cavity. It's a loosening of a segment of the chest wall, and this is very severe because of the implications that it can cause on our respiratory system. So some signs and symptoms of this are that respiratory distress. That person is having a hard time breathing. They're not in respiratory failure, nothing like that. They may be breathing really fast or having just a hard time moving. And so, like we do in our examination, if they're having a hard time breathing, are you monitoring at the B stage or that head to toe stage, they're going to probably present with some pain as well. We're going to expose that chest, and what we could see here is this thing called paradoxical chest movement. I'm going to be posting a video on Google Classroom demonstrating this on a real life patient, where one side of the chest is inflating and the other side is not. It's a really weird thing to see in reality, and this is a huge indicator that some of that chest wall has broken off and those lungs are moving in and out of that chest wall now, and that's a very, very serious problem. And there's nothing really we can do to treat this. Like I said, we are not surgeons. So our best form of treatment is going to be to stabilize this patient in that position of comfort. You can take some clothing, some padding, and put that underneath that flailed segment. You can put that patient laying on their side of that injury with that padding there, and you're going to apply a little bit of pressure with your hand to that flailed area. You then want to tape to keep that, segment is what we're trying to do in that anatomical correct position and not have it have any of that paradoxical movement. You're going to do some slight pressure, and then you're going to be taping this padded area firmly over that flailed segment. We don't want to encircle the chest in this treatment because we don't want to constrict any movement. This is basically all we can do. And then we want to rapidly evacuate this patient and always treat for signs and symptoms of shock because you don't know what those flailed rib segments have done to whether we don't want it to puncture a lung, injure that patient any more than has previously occurred. All right, so here's the video I will be posting on Google Classroom. Unfortunately, it is not working on my recorded slides right now. It is going to be demonstrating that flailed chest and that paradoxical movement. It's a really interesting thing to see on a real life patient, so make sure to check that out. Lastly, and most seriously, we're going to be talking about this thing called a pneumothorax. So pneumothoraxes are basically means a collapsed lung. Air has leaked into that pleural space, creating that negative pressure that then collapses the lung entirely. These can present themselves in a tension pneumothorax or a spontaneous pneumothorax. And that just basically means open or closed, like we said in head injuries. So a tension pneumothorax is where air has leaked into that pleural space is compress the lung and those major vessels around it. So some sort of hole or puncture, an open pneumothorax, as we call it, has created a one-way valve where air enters but cannot escape. And as that pressure increases, the lung then collapses, and this builds on those veins, and then the blood cannot return back to the heart. This is a very serious injury, and it usually presents itself with, you'll see that sucking chest wound. So that wound through that chest wall that breaks into that pleural space, the air then enters that pleural space, creating that pressure and that pneumothorax. We know how to treat a sucking chest wound, right? We're going to put our glove hand right over that injury site, and then we're going to dress that as quickly as possible with that occlusive dressing. I have a video on the following slide that will show that and highlight that treatment, and I will be posting that on Google Classroom as well. So with a pneumothorax, it usually presents itself again with tracheal deviation, which is what we're looking for in our head to toe examination. So it usually is to the unaffected side. So if the left lung has collapsed, the trachea will deviate to the right, and you'll be looking for that in your head to toe. Along with that, rib tissue is bulging, so those neck veins are going to start to distend. We're going to look for that jugular vein distension, right? The JVD as well. And there's also this thing called a spontaneous pneumothorax. It's basically a weak spot on the lung wall that gives way. And this is called, right, a closed pneumothorax. So this can occur while the person is at rest, and it's very sudden and spontaneous. So it presents itself with that sudden onset sharp chest pain and that increasing shortness of breath. And this can really mimic the signs and symptoms of a heart attack, but there should really be no radiating pain to the mouth or the arms or anything like that. So we're looking for that sudden sharp chest pain and that increasing shortness of breath. We're thinking maybe a collapsed lung. We then get into this thing called a hemothorax, where basically there has been a laceration of those blood vessels, and then that blood is starting to enter that pleural space, putting that pressure on that lung, and then collapsing it entirely. More than 1 liter of blood is usually needed to compress those lungs and compromise breathing. So as we've learned before, 1 liter of blood is a life-threatening bleed. And if that compresses that lung, that can lead to a life-threatening situation. We then have this thing called a hemopneumothorax, basically a combination of the two things we just discussed. Air and blood have leaked into that pleural cavity due to some sort of trauma, and then it is collapsing that lung. So these are very serious issues, something we cannot treat in the field, unfortunately, as wilderness first responders, but we're going to recognize these signs and symptoms. And like I said, it's usually due to some sort of chest trauma, unless it is some sort of spontaneous pneumothorax. They will present with a very rapid shortness of breath. They may be cyanotic, right? They're going to be starting to turn blue because that oxygenated blood that is given out to the body from that lungs is not getting to the skin, the epidermis. If you notice some sort of bloody cough, you may be thinking hemothorax, right? There's blood in those lungs. So it's a very serious issue. And the main treatment we have for this, other than knowing how to treat a sucking chest wound, is we're going to be maintaining those ABCs as best as we can. So if we may need to create that airway for them, and we may need to assist in breathing. If they're having a rapid breath or if they're having almost no breath at all, we know how to give rescue breaths, 1 every 5 to 6 seconds. We're maintaining any sort of circulation issues, and then we're just trying to rapidly evacuate this patient as fast as we can to the nearest advanced care. All right, finally, this will conclude our chest and lung injuries lecture. This is a video on an actual real-life patient of a sucking chest wound and the proper way to put on an occlusive dressing, the way this responder is doing. I will post this on Google Classroom because unfortunately, again, it is not working on my slides. I want to thank everybody for listening to this lecture, and we will see each other soon.